Welcome back to Save Your Thyroid with Jennifer Holkem, the podcast where we explore the latest innovations in thyroid nodule care. Thyroid nodules affect millions, with up to 70 to 80% of adults developing them. If you or someone you know has been diagnosed with thyroid cysts or nodules, you may have been told that surgery is the best or only option. But is that really the case? The good news is that groundbreaking non-surgical treatments are changing the landscape of thyroid care. Today, we're diving into two common treatments for toxic thyroid nodules: radiofrequency ablation and radioactive iodine. And though their acronyms are quite similar, these treatments are fundamentally very different. To help us break it all down, we're joined today by Dr. Ian Orozco, an endocrinologist based in Provo, Utah, with over a decade of experience specializing in thyroid and parathyroid disorders. With firsthand expertise in both RFA and RAI, Dr. Orozco will walk us through the basics. In today's episode, you'll also learn what are toxic nodules, how they differ, and why the treatment is important. RAI versus RFA, how these treatments work, when they're used, and what sets them apart. Patient considerations, how to choose the best treatment option for each individual. And the future of thyroid care, why RFA is gaining popularity, and what new advancements are on the horizon. Now, let's dive in. Dr. Orozco, welcome back to the podcast.
Thank you. It's great to be here. Thank you for having me.
Well, you and I had a conversation about this topic actually a couple of years ago. And I remember us having this conversation about how patients often confuse these two acronyms, RFA and RAI. And today we're going to set the record straight. But first, let's establish, can you explain what exactly is a toxic thyroid nodule and how it's different from other thyroid nodules?
So the major difference between a toxic thyroid nodule and sort of the more common thyroid nodules that people think of for RFA and for other treatments is that these nodules make thyroid hormone, and they typically make enough thyroid hormone that they make the patient sick. It's essentially a form of hyperthyroidism. But instead of like Graves' disease or other types of hyperthyroidism, it's the nodule itself that's making lots of hormone, which then makes the patient sick and have hyperthyroidism. The other nodules that we typically talk about or treat with radiofrequency ablation don't make thyroid hormone. And the concern there is usually either cosmetic concerns or compressive symptoms like trouble swallowing or hoarseness in the voice.
And so when you say they make the patient sick, describe what those symptoms are, because I know they can be quite debilitating.
Yeah, so it's the common symptoms that you see with other forms of hyperthyroidism. So heat intolerance, heart racing, weight loss, feeling really jittery, difficulty sleeping, all of the symptoms that you typically see with other kinds of hyperthyroidism. The exception would be that the Graves' disease is the one that typically causes eye problems where people have issues with their eyes. But outside of that, it causes most of the other kinds of symptoms that you see with other forms of hyperthyroidism.
Yeah, that's not something that a lot of patients are going to want to live with.
No, they usually seek treatment pretty quickly when they have those symptoms. You're absolutely right.
So when it comes to treating these toxic thyroid nodules, we've mentioned that the two main options we're talking about today are RFA and RAI. Are there any other treatment options that are often offered to patients?
In very limited circumstances, we will use medication. So the major disadvantage of medication is it doesn't fix the problem. So
Right.
with Graves' disease or other types of hyperthyroidism, the medication sometimes can be helpful or even make the problem go away in the setting of Graves' disease, but you're not treating the nodule. Mm-hmm. But in folks who can't have other treatments or can't do other things or refuse other things, we will sometimes use medication in that setting. Surgery is obviously also an option in the setting of a toxic nodule. But the primary modalities that, at least from a non-surgical perspective, are indeed RFA and radioactive iodine.
Unlike radiofrequency ablation, radioactive iodine and surgery have a pretty big consequence, which is permanent hypothyroidism. And
absolutely. So
that's something that we are really focusing on a
correct.
lot.
And that's primarily, right. And so in this instance in particular, right, if you have someone who you were either going to already have on medication, because they often actually present to my office on medication, the goal of the treatment in this setting, very similar to RFA in other circumstances, is for them to not require any medication after the treatment. I I would say to a degree, radioactive iodine might get a little bit of a bad rap. I think when it's done under close supervision with an endocrinologist who's very familiar with the treatment, that the rate of permanent hypothyroidism afterwards is probably better in surgery. This is one of those things where I think the literature doesn't quite bear that out. It leaves them pretty equal. If you look at most studies in terms of folks having surgery for a toxic nodule or having radioiodine for a toxic nodule, most of the time the rates of permanent hypothyroidism will be very, very close.
Okay.
I think if you see an endocrinologist, and I would say this is probably one of the circumstances where I think seeing an endocrinologist versus seeing a radiologist or seeing a surgeon who does these procedures, it's much more likely that the endocrinologist is going to be more familiar with dosing and techniques with respect to giving radioiodine. I actually used to give radioiodine as part of my practice. I don't currently because of financial concerns. I'm actually considering bringing it back because of the location of where I am and the frequency with which I see patients with thyroid cancer and hyperthyroidism. But in my clinical practice, I would say the rate of permanent hypothyroidism is probably about half of what it is in surgery. So you can expect in surgery to have sort of a 20 to 30% rate of permanent hypothyroidism. I'd say my clinical experience is probably closer to around 10%, which is better than typically what you see in the literature. I have been doing radioiodine now for 10 years, and even when I don't, when I'm not the person giving the isotope, I will request a specific dose that I want specifically for that patient, for their particular nodule, for their particular degree of hyperthyroidism. And each patient is a little different, and I think we'll get into what nodule characteristics and when radioiodine is right and when it is not. I also probably benefit from not recommending radioiodine when I don't think it will work, or if I think that it's likely to cause permanent hypothyroidism.
So what exactly is the radioactive iodine? Is it a medication, like a pill or an IV? How's it administered?
So it is a pill.
Okay.
It's a radioactive iodine isotope that's for treatment is very toxic to the thyroid gland. That's by design. It actually comes out of a nuclear reactor. When I speak with patients about radioactive iodine, it's very important to distinguish between two different isotopes.
Okay.
So we're going to get a little into physics and nuclear radioactivity, but there's one isotope called I-123, and I-123 does not hurt the patient. And so we use I-123 to take pictures to give us diagnostic information. So for example, if a patient comes and sees me and has an overactive thyroid and has a thyroid nodule, I will get what's called a radioactive iodine uptake and scan. And so that is a test where they give you a little tiny amount of isotope that does not hurt the patient, does not hurt the thyroid, and it's used to take a picture. That's actually how you tell that the nodule is making thyroid hormone and making the patient sick. So if I have a patient who has two nodules and they're hyperthyroid, I don't know, is it one of the nodules? Is it both of the nodules? Which nodule? And so particularly for radiofrequency ablation, you need to confirm which nodule is making thyroid hormone and is making the patient sick. You need to do that for radioiodine as well, because you need to see, one, how much of the gland is making too much thyroid hormone, and two, they actually give you measurements of how much of that radioisotope is taken up. That's actually very important because I use that to determine the dose of radioiodine that I give for a treatment. And that will play a role in whose nodules are good for radioiodine and whose nodules are not. Both isotopes are actually a pill. It kind of looks like a 1980s Tylenol gel cap. A lot of times when we talk about radiation in the thyroid world, patients think of, they get stuck in the machine and they get zapped and get burning on their skin. If they've had family members who've had other kinds of neck cancer or other issues, and there are a lot of different concerns with that. It's actually a pill. It used to be kind of a Kool-Aid. So if you look at people getting radioiodine before the 60s and 70s, we've been using radioiodine medically since the 1940s. It was actually a liquid that they had them drink. We don't do that anymore because it's toxic for the people handling the material and giving it to the patient. It's actually the same stuff. They just inject it into a capsule. And so then when you order the isotope for the patient for treatment, it's a special individualized capsule that you can make whatever dose you want it to be, whatever you think is going to be best for the patient, and it is specifically for them. And so it's a little different than other medications or other things where it's, not always just, 100 micrograms of Synthroid or 112 micrograms of Synthroid. It'll be a different dose of radiation for each individual patient that should be chosen by a clinician who's familiar with doing this. Many hospitals and institutions institutions, if they don't have a specific direction, they will have a rote or an empiric dose that they give for hyperthyroidism. And that may be not enough for some patients, and it may be too much for others that sort of pushes them into that permanent hypothyroid phase that we want to avoid.
That is really interesting because I've literally never heard of radioactive iodine not causing permanent hypothyroidism. So I guess that dosing that you're talking about that's very tailored to the patient's nodule is quite important, and maybe something that's not quite so common, in the world of treating these toxic thyroid nodules. Am I misunderstanding that?
No, I think that's pretty accurate. I think part of it is there's a conflation between the different diagnoses. So Graves' disease, for example, Graves' disease, autoimmune problem, tricks the whole thyroid gland into making thyroid hormone. When you do that scan, instead of getting a little dot or a little nodule that's making hormones, the whole gland, right? So years ago, they tried to dose folks perfectly for Graves' disease, kind of like what I'm talking about for a toxic nodule, and it doesn't work. And so the reason it doesn't work is that if you leave enough tissue behind in a Graves' disease patient, eventually over time they'll become hyperthyroid again.
Okay.
And so in Graves' disease, you're correct. And so there's different treatment goals. And I know that's not specifically the topic today, but in Graves' disease, you're actually trying to kill off the whole thyroid, because if you don't, it's going to come back. Whereas with a toxic nodule, it's a little different, because if you have a nuclear medicine scan for Graves' disease, you can actually see the butterfly shaped of the thyroid gland, and it's making tons of hormone. It's soaking up all of that iodine. If you have a pretty small nodule, you're going to see a little spot, and then you're not really going to see much of the thyroid gland itself. And so that picture actually tells you how much of this gland, how much is going to take up the radiation, and how much is relatively protected from the radiation. And so the bigger the nodule, or the more efficient it is at taking up radioiodine, the more of the radioactive material it will take up, which then can affect your dose. And if the nodule is very large, right, so if I have a patient who has a nodule that takes up half the gland, well, then if I kill off half the gland with radiation, that's not going to be very different than having surgery. And so that kind of goes to my point in terms of when you look at thyroid nodules and toxic nodules, how big is the nodule? How well does it take up radioiodine? Those are all important considerations for whether or not you should consider surgery, you should consider radiation, or you should consider RFA. That is going to be one of the important components.
Awesome. Thank you for clarifying all of that. I'm learning a lot today. Well, I feel like this is such a really great learning opportunity, not just for the viewers, but for myself.
Thyroid disease in the thyroid gland is a black box to a lot of physicians. And, I have conversations with other endocrinologists who don't specialize in thyroid, and they don't have experience in terms of dosing and deciding radioactive iodine, or certainly RFA, which we know is gaining traction, but there's still a lot of folks who, I even had a patient recently who told me that their doctor told them it was experimental, being used for 25 years. And there's actually an endocrinologist in Italy that was doing RFA in the 90s for thyroid. So it is not experimental. It's a new technology in the United States. There's a whole lot of medical, legal, and political reasons that we're not going to go into for that. But it is not an experimental technology by any stretch of the imagination.
By any means, not at all. So my next question for you is, since we've established that it's very important for the patient to have a very customized dose tailored to their specific situation, what then are the potential side effects and risks for that patient undergoing that radioactive iodine treatment?
It's not the most important one, but I will say this: radioactive iodine is inconvenient. I usually tell folks when we talk about radioiodine for either thyroid cancer or for a toxic nodule, you kind of have to block off a good 3 weeks of your life. And so there's some controversy around this. I'm going to talk about how I do things. Like I said, I think I've had very good success with radioiodine. One of the things I like to do before scans and before treatments is I do have my patients follow a low iodine diet. So the number one reason in the world to have a thyroid problem is lack of iodine in the diet. And that's why most industrialized nations put iodine in their table salt. It's basically a public health measure. And so any iodine in your system will compete with either the tracer or with the treatment. Now, there's some literature says it's helpful. There's some literature that says it's not. Again, I'm going to go with what I do because I found it to be very effective. But I typically, for a radioiodine treatment, like to have folks on a low iodine diet for at least a week, if not 10 to 14 days.
Okay.
The second thing about a radioactive iodine is that you can't be around other people for the treatment. I had mentioned earlier in the podcast about for the diagnostics, this does not apply. And so again, I-131 treatment, you have to basically quarantine yourself. So you're literally radioactive. And so you will not, for hyperthyroidism, you will not be able to be around other people for a week to 12 to 14 days, depending on the dose that's given. And so that, has impacts with respect to going to work. It has impacts to, if I have a patient who someone is, helping them in terms of a caregiver. So I have an older patient who someone has to help them with daily living. That is not going to be a very good option. So I wouldn't really call that a side effect, but it does kind of go into, I think, is the next topic that comes up frequently. So thyroid disease in general, thyroid nodules, hyperthyroidism, all more common in women. And so giving folks doses of radioiodine does have a tangible impact on the frequency of breast cancer. So if I have a patient who has a family history of breast cancer or a personal history of breast cancer, I'm going to be less inclined to recommend radioiodine in that setting. It's not a huge increase. The scientific knowledge and scientific background and work on this is actually still ongoing. It is dose dependent. There was a time that it was felt that it did not cause it on the doses that we use for hyperthyroidism. So a dose that I give someone for hyperthyroidism might be, 10% of what I give someone who has thyroid cancer. So we've known for quite some time that the dose of iodine we give in the setting of thyroid cancer does cause those problems, but you're doing it you're treating another cancer, you're treating something else. Mm-hmm. And in those instances after surgery, there isn't really other treatment options available. So you're sort of wedged into doing that.
Right.
It's very different if you're doing it for hyperthyroidism because you have other treatments, even surgery, which obviously is not something that we're generally trying to encourage people to do unless it's required. But it's very different when you talk to a young woman who has a family history of breast cancer, and you're talking about a treatment that can potentially cause that down the road. Similarly, when you do radioiodine, female patients should not get pregnant for at least 6 months, if not a year. And so if I'm seeing a patient who is, wanting to add another child to her family and she's, getting close to the time frame where we're talking about menopause or troubles with conception, that's not something that we're really going to be looking to do. If I'm going to tell them, I really shouldn't get pregnant for 6 months, my professional preference is a year. And so those are sort of not side effects or concerns, but it's in terms of symptoms or things to look out for, but it's things that patients need to be informed about before you do radioiodine, because it has a long-lasting impact. And that is, in many ways, comparable, worse, depending on person's opinion and the things of being on thyroid hormone, right? So if I have someone who I've done radioiodine, I've dosed them successfully, they don't have permanent hypothyroidism, but then I've increased the risk of breast cancer, it's a trade-off that I find actually relatively frequently is something that women don't want to pursue for that reason. The literature for other solid tumors or for blood cancers is much less clear for the doses for hyperthyroidism. It is well established for thyroid cancer that you are increasing risks of other kinds of cancer in those dosing. The literature doesn't support that for hyperthyroidism. I don't know that I'm comfortable enough to say that that's not the case. The treatment itself, other than the inconvenience, is actually pretty anticlimactic. I mean, you go to the hospital, or if you see a thyroid doctor who has their own hot lab, it comes in a device, it's called a peg, that helps protect us from handling it. And you literally take it out and hand the bottle with the pill into the patient, and they take it, and then they very quickly get ushered out of the building because they're radioactive. So that in and of itself is not, it's relative. If you didn't know what you were doing or what you're taking or how the people around you who were behaving when they gave it to you, it isn't that impressive. In terms of side effects for the patient, the major one that we keep an eye on is damage to the salivary glands. And so the radioactive material comes out in your saliva, it comes out in your sweat, and it comes out in your urine. And there's very specific precautions that are done for usually 48 hours after an iodine dose. But one of the things I always encourage my patients when I do radioiodine dosing is for them to stay well hydrated, because if the radiation collects in the salivary glands, it can cause the damage to the salivary glands. There can be disruption in taste. There can be disruption in a permanent dry mouth. Those are very atypical for the dose that we typically use for a hyperthyroid patient. That tends to be something that we're more concerned about in the setting of treating for thyroid cancer. But I find between the precautions, between the period of time to not get pregnant, the risk of breast cancer, and there's actually also literature that it shows that women will be more likely to go into early menopause if they have received a radioiodine dose. So there's a lot of fertility concerns that often come up. It's again because these are problems that are much more common in women than in men. And my practice has kind of gone that way. Pre-RFA days, at least, my male patients were much more, I'll just do iodine. I don't have surgery. Like, let's do that and get it done. It's a much more nuanced conversation with the female patient. So I used to practice endocrinology in North Carolina, and I was near Camp Lejeune, which is the world's largest marine base in eastern North Carolina. And this was during the time when it was war on terror, and we had lots of military overseas, and you'd see this young lady from Oklahoma, and she'd have an overactive thyroid, and you'd go through all these things about avoiding other people. And, you tell this woman from Oklahoma, she's got 4 kids at home, and you tell her that she can't be around her kids for 2 weeks. And she looks at you like you have 3 heads. Like, there's just no way that she's going to do that. Yep. And so my use of radioiodine in that practice setting was very small because a fair number of my patients were military or military spouses. And when they're in that situation, that was kind of why I let off in the beginning. That is not a side effect. That is not something to watch out for. It's not something bad that happens to you. But when you put together the low iodine diet, which is not fun and actually a little difficult to do, and then the exposure to radiation, which I think oftentimes, and I'm glad you asked about how it's given in terms of the pill, sometimes when I talk radiation, people think Chernobyl.
Right.
And then after that, you tell them they can't be around their family members, whether it's an elderly loved one they're caring for or the children, or some people, I don't want to take off 10 days worth of work because I'm radioactive. And so there's a lot of barriers to doing it outside of the health concerns, but that is definitely one of them. They would really look at you like, is he really telling me I can't be around my kids for 10 days? There's no way I can do that.
Well, that's real life.
It is real life, exactly.
Those women were, like you said, she's away from her family, her husband's off at war, and she's got these children that are depending upon her. There's no real life way that scenario works itself out. Right. And so I think it's amazing that we can talk about this other treatment option that doesn't involve any of that. And so now let's go into discussing RFA.
Yeah, so radiofrequency ablation, which I'm sure most of your viewers know, is one of the thermal ablation techniques that we use. It's high-frequency radio waves, essentially electricity, that's used to target the nodule in question here. And so in terms of the hot nodule, the goal is to ablate or destroy all of the hot nodule while preserving the rest of the healthy thyroid tissue. To some degree, the target and the idea is the same as radioactive iodine in terms of trying to make sure you only are destroying the tissue that you want, and so that the rest of the thyroid gland is preserved and maintains normal function. It is one of several thermal ablation techniques. Microwave has been gaining some popularity of late. There have been a couple new devices now that have been approved in the United States for microwave. I'm partial to radiofrequency ablation, and I'll comment on that a little bit further when we talk about actually treating nodules and nodule selection. Laser is also a possibility, and there's a new sort of nano pulse wave technology that's currently emerging. There's a handful of studies now for those techniques, but they're all roughly the same, which is you're using, either heat or mechanical motion. There's other countries that do high frequency ultrasound that's not available in the United States. But the idea is roughly the same with all of them, which is that you're targeting the tissue that's causing the problem and sparing the tissue that's an innocent bystander and just happens to be there.
And for those people who are new to this channel and they don't understand how that energy is applied, describe the process of putting that energy into that nodule.
So it's an ultrasound guided procedure. So I actually kind of joke, it's like doing a thyroid biopsy and sewing had a baby. So it's because it's an ultrasound guided procedure, but instead of sticking a needle in the nodule to get cells to make a diagnosis, you're sticking an electrode in the nodule, and then you're activating, in the case of RFA, the RF generator that then heats the tip of the electrode and then basically cooks the cells that you want to destroy. And so it has to be done under ultrasound guidance because you have to see the tip of the needle the whole time in order to make sure that you're targeting the appropriate tissue. But it's done in the office. It's done as an outpatient. I actually do most of my cases with Valium. I actually prefer not to do conscious sedation. I like to have a patient that can very readily and easily interact with me. Sometimes when there's nodules, if they're near certain structures, there's a nerve that goes to the voice box called the recurrent laryngeal nerve. We don't want to damage that when we're doing the procedure. So I like to have my patients pretty awake so that they can converse to me. I just simply have them count if I'm, doing a treatment near that target area to make sure that we're not causing any issues while I'm doing the procedure. Most people don't describe much in the way of pain. We use a local anesthetic. It's not just the simple, sticking the lidocaine in your neck and then giving you a shot. There's actually a very special technique we use where we put a layer of anesthetic liquid between the capsule of the thyroid gland and the surrounding muscles and structures. So one of the convenient things for RFA is that the thyroid nodule itself does not have any pain receptors, and the thyroid gland itself does not have any pain receptors. It's the capsule that has pain receptors. So if you put that nice layer of anesthesia around the thyroid gland itself, it sits there while you do the procedure. And so there's literally lidocaine sitting on the pain receptors around the thyroid gland. And pressure is the most common complaint. And then sometimes if I'm close to the capsule on the lower side of the thyroid where I have not put anesthesia, I can have folks that will note some discomfort. Most of the time, patients are actually pretty surprised, one, on how it was not painful when they had the procedure done. And honestly, also afterwards, I typically call my patients 1 to 2 days after the procedure to check on them. And most of them are like, it's a little sore. I haven't really had to take any Tylenol or ibuprofen or really do anything. It's not without complications or issues, but by and large, folks do very, very well with having it done. Pain is a very subjective thing. So I always kind of tell folks, this is not something where you're going to you're not going to come back for an RFA party. Like, I get it. It's a procedure. It's going to be uncomfortable. But overwhelmingly, most patients say it's not nearly as bad as they expected it to be.
And how would you say it compares to surgery as far as the recovery aspect?
I think the recovery is much better and much faster than surgery. Obviously, the first issue you're going to have with surgery is that you have an incision and either stitches or surgical glue or something else that has to be maintained or cared for. You can get an infection of the RFA site. I've actually clinically never had that happen, but you don't have the restrictions in terms of lifting weights, how much weight you can lift or certain motions the next, at least for not as long. I usually tell patients to take it easy for the first 48 hours or so. And by and large, after that, most of the time people can go back to completely normal activity. There's no reason to not eat or drink or anything the same day after an RFA procedure. Most of the time when patients are discharged from the hospital, that's pretty similar. But usually it's a sort of 2-week window where you're kind of on eggshells after surgery, and I'd put it more at about 48 hours after RFA.
Yeah, the whole idea, like we were talking about a moment ago with the radioactive iodine and that being separated from family and children and whatnot is also a common concern for a lot of our patients after surgery. And so considerations to the recovery process are quite important, regardless of the treatment option chosen.
Absolutely. Just like with the radiation, the young mom who doesn't want to have to avoid her kids for a week. Well, I don't want to not be able to pick up my toddler for 2 weeks either.
Right.
And so, yeah, no, absolutely.
And also equally important, if not more important, is how effective is it? So in terms of comparison to radioactive iodine and surgery, how would the effectiveness of RFA fall in there?
So this is a distinct depends. And this goes to my comments earlier that every patient and every nodule is different, whether you're dosing it for radioiodine or you're selecting radiofrequency ablation or you're selecting surgery.
I'd like to take a moment to thank the sponsor of this episode, Cambridge Interventional. Cambridge Interventional, a US-based company, has decades of experience in development, manufacturing, and sales of RFA and other medical devices. Radiofrequency ablation is a non-surgical, minimally invasive thermal ablation procedure used to treat various tumors, including thyroid nodules. If you have watched this channel before, you know that I personally underwent thyroid RFA treatment for a very large thyroid nodule and was able to save my thyroid and avoid surgery. If you'd like to learn more about Cambridge Interventional, please visit their website, cambridgeinterventional.com. A big thanks goes out to Cambridge Interventional for helping physicians to save thyroids and also for supporting this channel by sponsoring this episode. Now, back to the podcast.
So for RFA in particular, RFA of a toxic nodule, of a hot nodule, is a different process, different strategy than just a large nodule, right? So if I have someone who has what we normally think of, the large nodule on the thyroid, and it's causing some cosmetic concern, and they have trouble swallowing. If I go in there and it's a big nodule, and I shrink it by 60, 70%, a lot of times that will actually relieve the patient's symptoms, right? If they don't notice as much, or if they no longer have trouble swallowing, patient's happy. I might not be with 60 to 70%, but nonetheless, the books will tell you that that's a successful treatment. And many times, if they shrink by that volume, the patient will also tell it's a successful treatment. The primary difference between a toxic nodule and a non-toxic nodule in RFA is when you RFA a toxic nodule, you have to get the whole thing. If you don't ablate all of the tissue, the patient will not be better. And so you can get shrinkage by 50%. And their thyroid levels don't go back to normal. And so the treatment goal is a little different. In fact, most of the time when I recommend RFA, it is not a nodule that the patient can feel that is there, because RFA is much more effective in smaller nodules. The smaller the nodule, the more effective RFA will be. The larger the nodule, the less effective RFA will be. As a general rule, my kind of way of looking at it when I talk to patients is that you can go in order of efficacy and then the likelihood of ending up on thyroid hormone. Surgery is going to work. Surgery is going to work. If you take out half the gland, you take out a bunch of tissue you didn't need to, it's going to work. But the patient has the highest probability of having permanent hypothyroidism. Radiation will work not as well as surgery, but in many cases better than RFA. So if you have a nodule that's, if I have a 40, 50 cc thyroid nodule, that's not very likely to do well with RFA. So if you have a very large nodule, the treatment success for RFA can be as low as 40%. If you have a small nodule, less than 20 cc's, then you're in the 80% range, 90% range. This is an area where having someone who has a lot of experience doing RFA is very important, because as it gains more traction and as we have more people doing the procedure, as I mentioned, if you have a large nodule, it shrinks by 50, 60%, patient's happy, they feel better, they don't have issues. That's very different than doing RFA, because you really have to make sure that you ablate all of the tissue. And so it's partly dependent on the size of the nodule. There's emerging data that also suggests what the nodule itself looks like. So if you have a nodule that's large and cystic, so has lots of fluid-filled pockets, that is less amenable to RFA than a small solid nodule. So the perfect RFA candidate for a toxic nodule is going to be somebody who has a relatively small nodule that's mostly solid. And those are the patients where you typically have success with RFA. If you have that, big nodule, which you tend to see in older patients, if you have this big 5-6 centimeter nodule that's partially cystic that's making thyroid hormone, that's a pretty poor candidate for RFA. And so in those settings, I'm always of the opinion of laying out, here are the treatment options, here are the advantages of doing this one, here are the disadvantages of doing this one. But I'm also full disclosure. If I have a big nodule in my office that does not have great characteristics for RFA, we're going to have that discussion. Sometimes patients want to do that, sometimes they don't. And so this is more nuanced, I think would be the best way to describe it. Managing toxic nodules in general, but certainly when you're talking about RFA, is quite a bit more nuanced than the large nodule that has become kind of the norm in terms of what people normally think about for this treatment. One of the things I would caution when comparing the literature for toxic nodules, there's actually just recently a study published in one of the radiology journals showing that RFA is not as effective as radioactive iodine. If you don't stratify for the size of the nodules in your study, that doesn't really tell me anything.
Right.
Similarly, very frequently in these studies, they leave out the fact that a lot of the patients who received RAI are now hypothyroid. So you just traded one problem for another.
Right.
And so it is nuanced. I do think that there has to be some more thoughts and some more discussion with the patient and some more patient education in the setting of toxic nodules, because it's not as straightforward as the big nodule that my doctor said I had to have surgery and I don't want to have surgery. Most of the time we can help patients in that setting. Whereas with the toxic nodules, I am much more likely to not necessarily recommend RFA for an individual patient.
Would you say that the likelihood of success for those larger nodules might be higher if they have repeated treatments?
Yes, it does. There's a couple nuances. So I've had a case where we did a second treatment and that was successful after the second treatment. So that can certainly be made. You start getting into insurance questions when you do that. You start getting into cost questions when you do that. I haven't seen any literature on the topic, but when I do have that discussion with patients, I kind of tell them that the first time when we decide what we're going to do, it's a little bit of a fork in the road. And so one of the reasons for that is that the radioiodine treatment is dependent on how much radiation the nodule takes up. And so the less radiation that the nodule takes up, the higher dose of radiation I have to give to the patient. And so if I have a patient who I see for a hot nodule and we do RFA and they really don't want to have surgery and then RFA doesn't work, they might be less of a candidate for radioiodine because I will have killed off some of the nodular tissue, which then now that nodule is not going to take up a lot of the radioisotope. So I may have removed radioiodine from a treatment option for that patient. And so, unfortunately, I think to a degree, that's one of those ones that first visit when we talk about how do we want to approach that. One of the questions is, do you have any interest in radiation at all? So if it's the military lady who's like, I'm not doing that, you're crazy. Well, then your decision's kind of made for you.
Right.
And so I do certainly think there's something for that. I think, again, that's an area where having patient counseling and having someone who has a lot of experience doing this, saying, this is not a great nodule for this purpose, for RFA. So we can do it, but I give you a, 50% chance or a 40% chance that, we may need a second treatment in order to do that. And it's a percentage chance too. And so, you're going to have larger nodules that you do RFA and it's successful with one treatment. You're going to have that. And so it always kind of comes to the motivation of the patient. I do think that there is, a certain time or a size where doing RFA is probably not the smartest strategy. I had a patient with an 8-9 centimeter nodule that was making thyroid hormone. If I'm zapping over 2 or 3 sessions the exact same amount of tissue as if I send you to one of the surgeons, now we can get into scar and all that other stuff. But am I really accomplishing anything? I don't know. And so, I can't stress enough. Every patient is different. Every nodule is different. And, the treatment option is right for each individual patient, whether it be radiation, surgery, RFA, or even the dose of radiation is different. And that's an area where I think seeing an endocrinologist who's very familiar with all of the treatment modalities and how to handle toxic nodules is very important.
I completely agree with you. And, for the patient population, like we've been discussing a lot, this group that is predominantly women who are in their childbearing years, who aren't finished having children, or maybe their lifestyle doesn't permit them to be away from their children for a long period of time. It seems to me that the choice is really kind of then between surgery and RFA for these toxic thyroid nodules.
It usually ends up that way. I mean, I think most women, would say from doing this over the years, yes, you go through the risk of breast cancer, the likelihood of going through premature menopause, you can't get pregnant for 6 months, preferably a year. Those are all big no-nos for most young women. I would agree with that.
What about risks of the RFA procedure? Are there, a lot of the time, people ask me, does RFA cause radiation exposure?
Yeah, there's no radiation exposure with RFA. And I do think that is one area for patients when it's and you started the podcast off with that, which was radioactive iodine and RFA. They have similar sort of acronyms, similar sort of letters and naming for it. So no, there's no radiation involved whatsoever with radiofrequency ablation. It is directed electricity, directed radio waves, directed heat. And so it doesn't cause other kinds of cancer. It doesn't, damage other structures. You don't have to avoid other people. You don't have any of the things that you have at all with radioactive iodine. Most of the risks of RFA are obviously anytime you're breaking the skin, you have to be concerned about infection. It is done under sterile conditions. It's very uncommon in terms of infection following it. And then the rest of it is really to make sure that you don't damage structures that you don't want to damage. So the big blood vessels that go up to the brain run past the thyroid. You've got the vagus nerve that's typically out in that structure, in that cluster. And of course, the recurrent laryngeal nerve, which folks who have learned or read about or looked at RFA, that's a lot of what we talk about. There's this particular area that if it's a very large nodule, I'll just try and avoid. If I'm dealing with a hot nodule, a toxic nodule that's near the nerves, then I will do something called hydrodissection. The hydrodissection is a procedure where you use a needle to inject liquid between the structure that you want to avoid damaging and the nodule itself. Having some acumen and skill in that as a clinician who does RFA is very important for toxic nodules, because if I leave that little wedge behind on a big nodule, that may not be change the outcome with respect to the patient. But if I leave a little bit of wedge there and I leave a little wedge over there, then you've not completely ablated the toxic nodule, and then you didn't achieve what you wanted to do, which is that the patient is not hyperthyroid anymore. And so most of it is just physical in nature in terms of not zapping structures that you don't want to zap.
So I feel like we're getting there as far as understanding the key differences. And it's interesting too, it's not just patients that sometimes get these two acronyms confused. We sometimes even have physicians where patients come to the Save Your Thyroid community and they say, I asked my doctor about RFA and he thought I meant RAI.
Right.
And and then they're confused, and so we're always trying to explain to them that these are very different procedures. They have totally different mechanisms of action, and they have different outcomes. And so I think we've covered just about everything in terms of comparing the two. Is there any more features of RFA, RAI that we haven't exactly covered yet that you want to talk about?
I think that the take home message is that there's a role for all of the treatments.
Mm-hmm.
And so I certainly think in the right patient, radioactive iodine is a reasonable treatment option. I think RFA really should be considered as a first-line treatment. The North American Society of Interventional Endocrinology, NSOIE, is actually the only major one that currently recommends it as a potential first-line treatment. The ATA and some of the other societies are still, it's kind of an alternative. And so they're still really looking at radioiodine in surgery. I do think that if the goal is to stay off of thyroid hormone and it is the right nodule, it really should be considered as a first-line treatment. And I think if you're speaking to either a physician and hopefully not an endocrinologist who is not familiar with RFA versus RAI, then that's an area where you need to get a second opinion. Do I think RFA is right for every nodule? No. I think it is a highly effective therapy in the setting of the right nodule, the right patient, and the right physician doing it. And I think it's going to become more popular for doing this, but I also think that it's not right for every patient.
I totally agree with you. And I feel like the more I learn about this entire area of medicine, the more I realize that. I think my initial feelings about this 6 years ago were that, surgery is barbaric and you should never do surgery. And under the wrong surgeon's hands, that could be true.
Right.
However, there's some amazing, talented surgeons out there who save lives, and it's necessary in some cases for a patient to have surgery, as is radioactive iodine.
Yeah. My dad was a surgeon, and he used to refer to surgery as physician-guided trauma. So,
oh my goodness.
Yeah. So now there is a role for it. And when you have a busy thyroid practice, you will have some patients where surgery is actually probably the smartest option for them. Mm-hmm. It isn't always what they like to hear, but there is a role for surgery. There truly is. And I agree. I think as I've been doing this now for a few years and gotten more experience doing this, there are cases where you just go, I'm not really sure that this is the right one. But you also have the one where the patient has been told by, 2-3 other doctors, I have to have surgery. And you're like, right. No, no, you don't.
Right.
So, yeah, I think the key is every patient's unique. Every nodule, especially in the toxic nodule realm, is unique. And there are pluses and minuses to all three. And there's advantages and disadvantages to really the three major treatment options for toxic nodules. But RFA really should be considered as a primary treatment modality for toxic nodules.
I totally agree. And I think the key for patients here is that whichever procedure you're going to pursue, be it RFA, RAI, or surgery, you want to make sure that you're seeing a very experienced clinician who's got an understanding of these different techniques. Because we do see a lot of patients in the community who have been advised by someone who has no knowledge of RFA or other thermal ablation treatment options, and they advise against it. And I personally feel like that is not good medicine, because how can you advise against something you don't know anything about? You need to be willing to say, I don't know about that, but let me find out, or let me refer you to someone who does know.
Who does, exactly.
We see a lot of patients who come in for the second opinion or the third opinion, and when they finally do see someone like you were describing who knows all of these different treatment options, then they finally get the answer of, I actually do need radioactive iodine or surgery. But it's so important to understand that, not every physician out there still is aware of RFA. It is gaining traction though. We are seeing, like right now in our community, our list of physicians that do any of the procedures is up to 180 names, which absolutely just makes me so happy, because back when I met you a few years ago, it was probably up to 20 or 25. And when I first underwent RFA in 2019, there were two.
Yeah.
Two names.
Yeah, I was in what I kind of call the early wave of folks doing RFA, and because of that, correct, there are not very many of us. And I still hear, I'm in the Provo, Utah area, and I get a fair number of referrals from people either out of state or in rural areas where they're like, my doctor's never even heard of RFA before.
Right.
And most of the time, it's not usually, my endocrinology colleagues, and even most of the surgeons are aware of it. I'm starting to get referrals from surgeons in these areas who know, this patient might be a good candidate for RFA. So it is definitely, 3 years ago, I was never getting any referrals from a surgeon for, hey, I think I have a patient that might be a good candidate for RFA. So it is growing in terms of doing it, and I think it's going to be a very successful first-line treatment option for many patients.
What do you think is next?
In terms of RFA for toxic nodules or RFA in general?
Just on the horizon for thyroid in general.
There's emerging literature with respect to using it for parathyroid disease. So I don't want to wax too poetically on that, because parathyroid disease is actually one of my favorite disorders from a historical perspective. But when I was in training, which I like to think was not that long ago, the joke used to be, what do you need to find when you have someone who has an overactive parathyroid? And the answer was a surgeon who knows what they're doing. It's true to a degree, but that's more reflective of when I started training. The ultrasound machine I initially trained on was, half the size of a patient's examining table, and you really couldn't see anything in it. And so we weren't really using ultrasound to find parathyroid glands until I wasn't routinely doing it until about 2008. And so now if I can see the parathyroid gland on imaging, so hyperparathyroidism, let me back up. Hyperparathyroidism, there's 4 little glands next to the thyroid glands called parathyroid glands. They make a hormone called parathyroid hormone, and it causes the patient to have a high blood calcium level. And traditionally, the way that could only be fixed is surgery. Like, there aren't any medications for it. If you have this problem, you basically need to have surgery. Well, now, starting 20 years or so ago, people could find parathyroid glands on ultrasound. I actually still find areas and institutions that are not using ultrasound at all for parathyroid, but that's a completely different topic. But if I can see the parathyroid gland on imaging, and if I can put a needle in it to prove that it's a parathyroid gland, obviously the next step would be, can I stick an electrode in it and zap it? So the answer to that question is yes, that it can be done. And there's actually several papers now that have been published that's showing that it is an effective treatment for this problem. The rub is probably going to be, I suspect, that the complication rate, particularly damage to the recurrent laryngeal nerve, is going to be higher than surgery. Now, whether or not that changes as we get better at it and better techniques, right? It's the same thing when they started publishing papers 25 years ago for RFA for thyroid nodules. We weren't getting great nodule reduction size. The techniques that were used back then are not the same techniques that we use now. So just like anything with any emerging technology, that technology can get better. I think that's a possibility. I think it actually might mirror toxic nodules a little bit. I think definitely where the parathyroid gland is going to play a role in whether or not it's a candidate for RFA. And I think similarly, it's going to come down to experience of the clinician doing it.
Right.
So is that going to become a way that it's done? I'm not sure. And I'll say this, the reason I'm not sure is because the surgeons love it when I can go, there's the parathyroid. They know exactly where they're going. It's a pretty straightforward procedure. Kind of like my dad said that, surgery is physician-guided trauma. He also says the only minor surgeries are surgeries on other people.
Right.
So, whether or not it's going to emerge with that, I don't know. There's a nanopulse technology that's emerging for RFA. How effective that's going to be for toxic nodules, not known, no studies. It looks like it's going to be very effective for large benign nodules. I think the literature for doing RFA for thyroid cancer is a little more up in the air. I think if you'd asked me a couple years ago, I think I would have been more enthusiastic about using RFA for primary thyroid cancer than I am now.
Mm-hmm.
And so it's like anything with a new technology, the key is for patients is to see someone who is very familiar with what's going on now and what's coming on down the road. So I think there's going to be horizon for other aspects in thyroid nodules. I was actually part of one study that showed using it for recurrent thyroid cancer and lymph nodes. It has not widely gained any use for that. I think it's going to turn out to be as effective as surgery in that setting. And I think that as more people do RFA and people get more experience doing it, I think that's one area that will come up. Now, that's a pretty select patient population, people who've had thyroid cancer and then have recurrence in their lymph nodes. But I think if I'm talking about going through a second or third surgery for my thyroid cancer and I could have a good or equal outcome with RFA, sign me up. So I think that one will become much more common. Mm-hmm. Again, for primary malignancy, I think that's much less likely. I don't think the data is going to pan out that that's a great idea in that setting. And then parathyroid, it's hard to say. Most of the literature for that, at least with multiple patients, is international data, which I think always has some pluses and minuses when you look at international data. And it's going to be, that one I think is going to be effective. It's actually very easy when you do it because it's small. And so you literally just take a little teeny electrode, stick it in it, and push your foot on the button for 10 seconds and you're done. It's just a question of, is it going to cause more complications than surgery, which is currently the standard of care? And that's really part of it. Anytime you have a new treatment,
right,
you're comparing it to something that already exists. And so if it works, great. But if it's a higher complication rate, and then parathyroid too, it doesn't have the same issue in terms of thyroid, right? So one of the main reasons to do RFA for thyroid nodules is I don't want to be on thyroid hormone. Well, absolutely. That doesn't really apply to the parathyroid case. People don't need medication or don't need medication after treatment for hyperparathyroidism. So it's really a question of, does it work? And then does it have a comparable complication rate? And I think that last one is probably where it's going to not work out as good. I've had patients ask me for parathyroid, and I've been involved in one case. There's not a lot of it going on in the United States, but a lot of times I've just shown the ultrasound to the patient and been like, so there's where your nerve is, there's where your carotid artery is, there's where your esophagus is.
Right.
I got a lot of bad juju around there, and so it's hard. I'm also obviously looking at this from a private practice perspective. I'm a little more reluctant, I think, than maybe some of my academic colleagues to go off the reservation when it's something like that.
Mm-hmm.
So where that's going to land, I'm not sure. And so, kind of like you, I think we've gone from RFA for everyone to now it being it's getting a more nuanced as we have more experience. The country has more experience in doing it as the clinicians have more experience in doing it. But I think parathyroid's a possibility. And then I think actually recurrent thyroid cancer, it's very likely to be something that starts being used.
That's a conversation we've talked over at the THICA conference the last 3 years. We've actually presented multiple sessions for patients to learn about that. Because of the fact that the community, our focus in our community, Save Your Thyroid, those patients haven't had a thyroidectomy yet.
Right.
And the THICA patients, typically, they've already had a thyroidectomy and now they're dealing with a recurrence and they want to know, can I avoid a second surgery? So that's a different population than my typical population. And I think it's really helpful for them to learn about it because THICA primarily is dealing with more extensive disease that, would not be amenable to that treatment. So yeah, if for anyone watching this who's thinking about thyroid cancer, we've got all kinds of resources on that topic in the community, as well as on the THICA YouTube channel. We've got all of our previous sessions recorded there. Is there any final thoughts you want to share? Anything we haven't covered yet that you feel like you want to add to our conversation? I feel like we could continue talking for another hour.
My kind of the way I put it to folks when we talk about thyroid disease, whether it be toxic nodules or Graves' disease or large benign nodules, if you have the means, see a thyroid doctor, right? So, I'm close to the greater Salt Lake area. If I break my hand, I'm going to see a hand surgeon because I have that option. And I think as with telehealth and sort of other options, I think folks need to make sure as medicine becomes more and more and more specialized that they seek out someone who this is what they do. I mean, I see thyroid and parathyroid essentially exclusively at this point. So this is all I do all day, every day: ultrasounds, biopsies, and RFA. And if you have the means, I think that is probably the most important advice I can give to patients, because they will know things more, they will do things differently, and you're going to have hopefully a better patient experience, but certainly better patient outcomes in that setting, because those are going to be clinicians that's what they do all day, every day.
That wraps up today's episode. If you found this valuable, please like, subscribe, and share it with someone who might benefit. You can find links to everything we discussed in the show notes below. Find a physician, discover treatment options, and join our patient community at saveyourthyroid.org. To stay up to date on new episodes, resources, and expert insights, be sure to subscribe to my mailing list at saveyourthyroidwithjen.com. It's the best way to stay connected and informed. There you can also find all podcast episodes and book a 1-hour patient navigation consult for personalized guidance on your next steps. As always, please remember this podcast is for informational purposes only and is not a substitute for professional medical advice. No endorsement is given or implied for any specific product, treatment, or physician mentioned. As always, consult with a qualified healthcare professional for your individual needs. Thanks for listening, and I'll see you next time.